All right, our next presenter is Dr. Gregory Ator with the University of Missouri. Or I'm sorry, I just said University of Missouri. I can't believe I did that. Wow. That took a second. I just looked at Missouri. University of Kansas Hospital, excuse me. I'm a big KU fan too. Oh my gosh, it's late in the day. So Dr. Ator is the Chief Medical Information Officer of the University of Kansas Hospital and University of Kansas Physicians. He is also practicing, and I'm even going to try the word because I never can say it. How do you say it?
Otolaryngologist.
Okay, he said it. I'll say it wrong. Otolaryngologist. I almost said it. With practice focused on medical and surgical disease of the ear. He has an undergraduate degree in electrical engineering and over 10 years of practice and training in medical informatics. He has acted as the physician champion for the installation of several different electronic medical records in multiple surgical and medical ambulatory clinics, as well as computerized documentation and order entry systems for the inpatient domain. Dr. Ator, a supporter of the digitalization of medicine, feels the next few years will be incredibly important to the future of American healthcare. Heretofore, physicians have been enduring the difficulties of digitalization with the challenging transformation of scribbles on paper to characters on computer screens. Soon we will be able to harness the information for the benefits of our patients, practices, and the greater society. However, even as these positive developments occur, physicians must be actively involved in the transformations as we replace the pen with the tools of the digital age of medicine and capitalize on newfound capabilities. I love that paragraph. I think that's very, very good. So welcome, Dr. Ator. Did you want this?
Okay. Does that everybody hear me okay? All right, good afternoon. Yes, I'm a KU kind of person. So Linda, it starts off the jokes. I do have, I know it's kind of hard to do humor with some of this kind of material, but I do have a couple of things. And let's see, one might be trying to get this slide. All right, I'm gonna start out with a little before and after paradigm. Here I am with my feet up on the desk here and just enjoying life. We've got the log on screen here ready to go. And you can see the quote down there. This is before meaningful use. I have several decades to get people to use the problem list. I can get them to respond to suggestions to do the right thing. We'll work this out together. And I thought this was gonna be a nice, sort of the final phase of my career, we can kind of work through all this. And of course we all know that's really not the way it is. This is only the first stage of meaningful use. That's what everybody says to me. How many stages are there? But listen up, folks. We have to maintain the problem list, med, and allergy list, and get the best discharge summary out faster than ever before. That's quite an accomplishment. And quit scratching little things on those scripts. Give me that pen. I'm going to trash that right now. And I actually have done that. I actually go around and collect script pads and secretly make them disappear. So here we are, though. I'm thinking after several more years after MU5, we're going to be better. I mean, I think Brian has got the answer. It's out there in big data, and things are going to be better. But this is just it's not a real joke, because I really do believe that in time, as we start to align, all the factors that are playing into this whole EHR rollout, I think doctors are going to get happier, because I really think that fundamentally, after the hyperventilation is over and the I'm not going to do that stuff, typing and all that is over, it really does, it's a great way to take better care of patients. And I think that's really what doctors are in the main interested in. So there's the quote about, you didn't go to everybody's heard this, half your life to be a typist. And then the internist, I am a surgeon, so I take a particular exception of the internist comment, but you can't hurt me anymore. So here I've got my feet up again. So, but this is the current, I really like this. I feel sorry for the guy. We tap a button, we get a pellet. He taps those buttons 1,000,000 times a day and never gets a pellet. And here's the attending faculty over there. So, that really is where we are. And as I said, I think as we align things from a volume-based system right now, where these computers don't help us hurry up. They don't help us do what we perceive somewhat misguidedly that we ought to be doing. And so I really do think in time we're gonna get better, and particularly when meaningful use, that whole elephant is swallowed by the vendors, and they get into making systems more intuitive and efficient. So it sounds like you guys have already talked about those. I'm sorry I missed the talks this morning. They sounded like they were really great, good material. But I think the key sentences here, and why I do believe that this computer is going to help us be more successful physicians as well as successfully pay our bills, it's really paying you for performance instead of just doing something, which is the current paradigm. So we're really straddling this volume-based paradigm with a tool that really excels when you start talking about data and outcomes. So I think that's part of the problem. I did want to talk a little bit about the CMIO role. I about 2005 took the position at KU, and it was kind of an interesting story relative to making a big system selection, and the IT folks wanted to have meetings at like 2 o'clock on Thursday, and they couldn't understand why no doctors come. And I said, the doctors that we want to hear from are seeing patients at 2 o'clock on Thursday, and they always will be. So we need to have these meetings at 7, noon, 5. We need to have food, all the things that I think CMIOs kind of help in terms of just the moving the projects along. And the complaining, it's hard for, I think, sometimes technical people to really respond appropriately to the complaining, and to just tell them, look, we're going to do this. There's no question about it, and so that's why I hold my head sometimes, but and have holes in my back. That's my job, is to take the insults and hopefully respond in an appropriate manner. So I think another factor that really helped was a practice that joined our group that had a long history with a record and had really done some great things practically with it. So as I indicated with Linda, I do try to keep my finger in the clinical program. It does irritate my boss quite a bit, because my CIO boss / partner, because he has a hard time understanding, what are you doing during the day? How come we can't have a meeting 24/7? Well, I've got these patients, and they're lined up for months in advance. But I do think that's important in an informatics kind of champion, that you help bring the voice of the practicing doctors. And I really don't want to say my people tell me that it doesn't work. I want to be able to really speak to that directly. So I steadfastly stick to that in spite of all the difficulties it causes. And this little diagram at the bottom, I think, really sums up what informatics is all about. The people, process, and technology are always part of these projects, but the technical system, no matter what vendor you have, they all have their strengths and their weaknesses, and they're not all the same. So you pick a vendor, and it can do certain things for practice, and it can't do other things. And the challenge is to kind of meet in the middle, or somewhere get this to kind of balance out, where you use the strengths of the system to gain efficiency where you can. You got to do those workarounds where it doesn't, but you have to sell that to the clinical audience, and you have to make sure they understand that that's, we're not writing software at KU. We're simply configuring software that thousands of other people have written for tens of years somewhere else. We're not writing software. So that's something that they need to understand. I will say that this whole idea of a CMIO meshed quite well with another program at KU, which has, I think, had a lot to do with the renaissance of our institution over the last 15 or so years, from being in single digits with patient satisfaction and mortality issues to really now in the top tiers of really both of these measurements in terms of excellent patient satisfaction and low mortality. We have this emphasis on the five stars you'll see there, and we actually invest a lot of money in this, over $3 million annually, with direct compensation to physicians to buy their time to participate in these various initiatives that pair a physician with a with a partner, and that a hospital partner. And I'm not saying we spend $3 million on informatics, but the whole program, with about 85 doctor participants, covers the whole gamut from performance around the hospital to how can we improve patient satisfaction in different units. So they can be unit-based, they can be program-based, like liver transplant, and then some of them are kind of special areas like this informatics group. So I have 16 physicians that work with us in this, all sorts of specialties there. I have an ambulatory lead and a inpatient lead, and they sort of both, well, all of these folks report to me. We've got, you can see the specialties covered there, and quite a bit of surgical input. Again, surgeons have a very difficult time with the whole EMR concept in general. And I think that's actually been a good thing that I'm actually one of their peers. I actually do operate, I actually do everything that they do. And, you know, orthopedics just went live, so that's a good thing to have, I think. So I do also partner very heavily with the clinical informatics people, or nursing informatics they're called now. We're trying to really combine forces and really bring nursing and the physicians together, because we have many of the same needs, that is like optimization requests, prioritizations, education, the people process piece that is really quite similar between nursing and physicians. So we partner very heavily with them. A great example of this was in our recent, well, now we're coming up on about 3 years of CPOE. We have 100% use. And it really was a major renovation of how the hospital does business on the clinical side. We had 5,000 orderables in our charge master that a person, we had 8 different ways you could ambulate someone. And, you know, now we've taken that 8 down to 1 order that says ambulate. And it has all the sub-decisions that you can make in there. And so a lot of just kind of reconfiguration of the way the hospital works. 1,200 order sets, paper, many of them duplicative, many of them with a 30-year history. You know, where did this order set come from? Well, we don't know. That guy has passed away. But, you know, we're still using that was an OB thing, order sets. OB is one of our highest DRGs in terms of volume. So we really started to apply lots of filters around specialty parity to make sure every specialty had some order sets. We tried to make it reflect the cost and quality opportunities that we had, and that was, as I said, just a complete redesign. So important partnership with them. So current state, this is all kind of build up. I'm going to get to the punchline here on value-based purchasing, but now, according to my colleagues, what is the goal of an EHR? That spell check thing, it always gets me. I'm already corrected that word. Sorry about that. You know what I'm talking about. So a lot of my colleagues think EMR is all about read it and find it. You know, that's what they think the point of this is. And there's good value there to read it and find it, particularly when they come from a system like ours where we had charts under Secretary's desk. We had shadow charts, we call them. You know, and we had more shadow charts than than anybody knew. And so, you know, so read it and find it is a good thing. But there's more to it. And I think that's the whole culture of the modern physician. They're really not terribly predisposed to learn about all this and to read all the emails that I send out that talk about the great things that we're going to do. But I think we're making progress in that. I do think you need to have professional, robust communication help. We actually have most of the time had a full-time internal communications person on our project. And of course, there's a big distinction there between education. It's hard to educate the communications people on what they need to be doing, you know, and the difference between the trainer role and the communication. Communication, of course, is that big coordinated campaign about why does this matter, you know, not how to do it, but why should you care. And we've really found that to be very effective. And it's an ongoing discussion, though, about how we're going to, you know, survive and thrive in the volume world, which we are in right now, but we're moving to a different state with things like the triple aim here on the left, and then the value-based purchasing arrangements like we've talked about. So where are we at KU? We did not really buy into the Big Bang model, although I would really have wished that we did. It takes a lot of resources. It was really not quite the approach, and particularly with the fact that we went with the clinical side of the house first rather than the revenue side of things. But so we've kind of been, I think, dying a death of paper cuts. You know, I mean, we first did our install in 2007. And that was MAR and nursing documentation. We did some ambulatory then, and we have been steadily doing, you know, projects. Our latest kind of big project is RevCycle, which is going in August actually. So we are for the most part done on the inpatient side, where we could be considered HIM 7, except for we don't have barcode up, but that's under are close to being underway right now. RevCycle I mentioned. We also have over 60 sites that we're trying to do to finish the ambulatory. Most of these are hospital-owned. The academic university practice is pretty much is completed, with ortho being the last people to get on the bus, if you can imagine that. So uptime, you can just see we're kind of moving through things. I will say on our data warehouse strategy, we have consciously not wanted to be a first adopter. We a number of years ago did some discussions with Knightsbridge and other big consulting firms, IBM and Mayo Clinic, and you know, kind of what went on with them, and we are moving along in that way. We have really at an academic institution, governance is super important. You know, just exactly what data are we going to collect, and what are we going to do with that. So we're trying to kind of work that out through some initiatives. Particularly an example would be I2B2, which is an open source software out of Harvard that actually every night, actually once a month, it takes a dump of the entire clinical database. Again, for political reasons, not financial right now, but it could do financial. And you can actually just sit down and do queries. If I wanted to find out right here from this computer how many people at KU are on a nose medication and are females, I can type that in and get an answer. It won't be exactly the number, but it is HIPAAized, and you know, I can't drill down to one or two patients, but it's really self-service to the clinical database. And you can get identified patients and do IRB qualified studies as long as you have that credential. So it's a very powerful system. We are starting to use it to do some multi-site collaboratives around the PCORI, which is patient-centered outcomes research. Lots of resources there, and a big emphasis on getting patients involved with clinical research. It's part of our CTSA effort. I think one of the most important things relative to our warehouse strategy is the business architect type guy that we hired from a prominent payer out of state, and he has really hit the ground running, and I think we're making a lot of progress with really getting the capability to do drill down, self-service type interactions with the data, so that clinicians can see exactly how they're doing and how their population of patients is coming along. So this is kind of the work plan he's got. We've got people, process, technology here on the left, the various components, and then to make sure that we do that in a sort of an organized fashion. Our institution is, you may have heard in the press, trying to do an integration deal where we're trying to integrate the clinical enterprise that is part of the university with the, which is basically the physician practices, with the clinical operation that is the hospital. And we right now don't have a lot of interaction and strategy. We've done pretty well without it, but it's something that really needs to be done, and so it kind of hampers these type of projects when we don't have a single financial body to make approvals on process and projects. So we're kind of working through that. One of the things that I think Epic has kind of a bit of a well-known issue with data and making sense out of your database. their approach in the past has been the clarity structure mentioned here on the left, which is a relational database extracted out of clarity, out of the production system once a day at night, and then you can run various reports on that. You can also run various real-time reports on the production system. But it's really pretty hard to do things with clarity, and you need some very seasoned people, and you know, the requests are always greater than what we have. But so we're working through that. Epic has suggested this Cogito sort of approach, which is going to allow you to integrate the non-Epic data on the right there, things like patient satisfaction, cost, and claims, and then to be able to integrate that together and really start to do some analytics on the combined data. So we're thinking that is going to be but as I mentioned, we're moving forward with some other tools, I think, that were mentioned in the previous talk, actually. One of the things that we really think is a very important part of the new world of medicine is that we practice to evidence, and that we really don't practice eminence-based medicine, which is, I said it, therefore it is. We want to inform that with evidence. So we actually made the decision a number of years ago to sign with Zinx, which is one of the leading vendors of order set type material, and they have many other aspects to it, including not only just what should your orderables be in your order sets, but what metrics should you follow in terms of quality. So they go out to the ACC, American College of Cardiology, statistics, and they really have it very much, you know, what sort of you know, needs are you going to have in your environment, your business model that you need to be paying attention to, and how do the interventions in the order sets impact that performance. So we, I call it zincification. We are in the midst of that process. So we didn't try to do evidence with our first run at CPOE, but rather we just translated. So we cleaned up the orderables and converted the paper order set mayhem to some very standard. We had about 240 or so order sets to go live with, and now we're circling back and starting to look at evidence. And particularly, I think, you know, it's one thing to have evidence in order sets, but it's another thing to actually use it. And so that's what we're starting to look at, is what are people doing with those recommendations that we make on order sets, and are they opting out of the best practice around antibiotic selection, for instance? Are they leaving antibiotics on too long so they don't discontinue them when they should? And a very robust data BI type strategy we think is going to be useful to getting at that. Mobility, we're really interested in this, and particularly in the context of the engaged patient, which I'll talk about in a little bit. Epic, our vendor, has a Fitbit API type approach where you can get data out of Fitbit and take it directly into the EMR. They have a very cool scale that I know a number of you folks have it. It's amazing how easy to use that is and how it works with the whole family. Of course, there's laboratory studies that you can do, and the compliance, you know, Wi-Fi pill bottles. So I think one of the issues that we have is how do you take this flood of data? You know, the Fitbit is just producing megabytes of data. I got mine on right here. It's probably, you know, collecting all sorts of stuff. I'm going to give me a little message about get moving here in a minute, but you know, it's collecting stuff all the time. And how do we turn that? And we need really like an executive summary of that. So we need a little glue technology to wrap all that up and tell us what we need to know out of this whole. So, and then of course there's the support aspect to it. So we think mobility and all of the engaged patient opportunities that presents are going to be important for us. I think one of the other very important aspects, and Joy, everybody knows Joy, I bet, back in the room, she is big time into our PCMH, was part of our initial foray into that, and the whole population management thing. So Joy, if I don't get this right, you'll help me, right? So patient-centered medical home, we actually are already certified. There's a new standard that's come out, and actually the specialty standards too, which we are planning on participating with, that are really going to be interesting for our specialty physicians to get involved in. One of the great challenges that that Joy and I have had is that these are all the entities at our place that are trying to do PCMH. And what is interesting is the IT needs of all of those groups are going to be very similar. So we have tried to herd the cats, to try to get all these people who, remember, PCMH is a very significant rework of how you do clinic, how you do your clinical operations. And so they've got that swirling around, and then we're trying to get them to kind of go to a KU model. So it's been very interesting to see the IT implications of these sorts of projects where we're trying to standardize things, to go from every department, our institutions doing whatever they can get away with politically to, or they have the finances, it's all different. Everybody at KU does something different. And if you've ever been a patient over there, you may, it's getting better, but we're still working through that. But all these departments do things different. They make decisions differently, they're funded different, their financial health is different. And so it's really been an interesting mix when you throw that people process sort of context, put a layer of IT on top of it. So we're working through that. Standardization is I say that a lot. So just to point out, is everybody familiar with PCMH? I don't know. Anybody? Should I keep going here? This is the 2011 standards you can see up at the top, but I highlighted in yellow really the HIT implications are what should be. And you can see, I think just about every single element in the whole program requires IT. I think demonstrating improved performance, I don't know what happened there, but I should have done that one. But the whole thing is just IT all over it. And so I think the real question though is it's not that single patient and the doctor in the exam room. I've got 30 patients today. How am I going to improve the care of these 30 patients? But the bottom here, where what can we as a team do to maximize the care of all of the patients that are in our practice? And that's really a different approach. It requires different tools. It brings up some issues. I think I've just tried to list a few of these in terms of diabetes. The registries are very big when you get into population management, but how do you know who's a diabetic? Is it an entry on the problem list? Is it, elevated blood sugar? Is it H1C that's out? There are many different ways to define it, but we have to get together as all of those practices and really codify about how we're going to define a diabetic. And we need to exclude maybe the gestational diabetics of pregnancy, or maybe not. So there's all sorts of questions around there. We're also discovering that terminology is really a very important aspect of our ongoing data-rich environment. And by terminology, I mean the vocabularies that you use to describe the medical problems. We have a vendor called IMO, which it works with Epic. It works in a number of Cerner shops. I don't know, Joe, how many Cerner places have it? A lot of Cerner ones, maybe.
It works with all scripts too.
Right, it's very common. And so what it's doing for us right now is it's actually doing our ICD-10 project for us, believe it or not, as far as the physician side of things go. Because what it does is I try not to talk to my docs about ICD-9 and 10, because those are fundamentally billing vocabularies. They're not about taking care of the patient. So we have SNOMED mapped to both 9 and 10, and right now, because we're not on 10, we show them ICD-9 plus SNOMED, and they pick. And so over the last 6 months, we've been seeing in our list of diagnosis that you can select left and right. Now, left and right is not part of ICD-9, but it is part of ICD-10. And so what happens, any left and right, I tell my folks, if you can find a left or right to use now, do it, because that will avoid a question when we flip the switch. Because every one of those is going to have to be fully specified when you see that patient. So do it now, and then it's automatically taken care of. But that's just the start. We also find that you need to really have very good controls on the back end about the definitions of stuff. Body surface area, for instance, we found that we were collecting that in several different places, and it really, everybody has one body surface area. There may be different ways to calculate it, but fundamentally, we need to try to stick to one wherever we can. And you need to prove to me why you want another one. and let's make sure we don't, stick to the one. So we've got those kind of data quality problems that start to interfere with a grand plan around data and performance when your fundamental choices that you made in setting things up cause this kind of irregularity. So we've engaged a consultant, and we're really doing kind of a major rework of how we do terminology from the front end, and that includes how you build out forms and to make sure that when we build structures that informatics are involved, and that we don't let doctors do things that require us to break the terminology standards and therefore maintain that from now till forever, and we really have to enforce those kind of standards. And so reporting, we need to do lots of reporting to manage these patients on the portals, on the panels, and then we need to get the report information out to doctors in an actionable way so that they can look and see, how am I doing today with my panel. I think another very important thing that you really get into hot water with clinicians on is attribution. So that is, who did such and such to a patient? Who is responsible for the diabetic care of a patient? In an academic practice, we have a hard time sometimes getting, if you're a solo practice, you can make this happen. Although a lot of solos, I think, would have a mid-level provider, and then you get that going in there. But presumably that mid-level would be working at the behest of another single physician. But in our group, where we have multiple doctors, multiple mid-levels, residents, attribution becomes a very interesting question. And as we start to publicize this, and I think it is going to start to be public record, how people are doing with various things, we need to make sure that we get the attribution part right. And you need to know that in order to affect better care. So, how do we change the behavior of providers as they're taking care of patients? And we really believe that the team is going to be an important part of this. I've listed, just as an example, some of the potential members. It's really everyone in the office, and we really have struggled with this to a certain extent, where no, front desk people can't, they can only do this, and the security in the system allows them to do this. Well, but what if we have a care paradigm where they could be helping the patient, deal with their insulin, or they could be educating the patient? How do you document that? And so we're really, I think, pushing the envelope with more to come around the various roles of these various team members. And because really, it's not, the patient needs to be at the center, but this is, population-based medicine is really not about what is the doctor going to do to make these folks well. It's really, what is the team, going to do, acting together to improve the health of the population and therefore the individual patients. So everybody's got a role, and they all have standards, and that means there's going to be data and reports that we'll need to use to make sure that is working properly. I think one of the other things is outreach. We've had some interesting conversations around the various, say when a patient comes to the orthopedic office and they need to have a colonoscopy, having that orthopedic department say, I noticed you need a colonoscopy. Can I schedule that for you? That's something that will be an interesting conversation when we get there. Don't you think, Joy? But it's all about taking care of the patient as a group instead of individual departments. So lots of interesting things there. I've advocated for Office of Patient Engagement. I really think that every interaction that we put together needs to have a view as to how is this going to impact the patient and how they interact with the physician and with the system. And so we've got portals, education customized to their needs, and in the Cancer World, navigators that really have a program that is really tailored to exactly what you can expect for a particular type of cancer process, and who you're going to interact with, and what's going to happen to you, and all of that is personalized and generated per patient. So it's been a tough sell a little bit with our communications people, but we're still working on that. My chart is something that we're rolling out that's the Epic patient portal. Right now we have fairly limited functionality as part of Meaningful Use 2. We really need to ramp up the use of it, and therefore we need to get really more value so that patients will want to use the system. And that's going to be a continuing challenge. One of the, I think, big wins for physicians is the concept of an intake process. So, when the patient is at home, instead of mailing them a $5 new patient info pack, you basically, when you register them for the appointment, you get an email, you send them a link, and then online they can fill out the new history that the doctor wants in reference to whatever particular problem they have. If they don't have a computer, we're going to have kiosk in the waiting room that allow you to do that. And then of course there's always the library. So lots of options for computers. After visit summary is another thing that is a big part of Meaningful Use. And I really think it's a great way to actually get to the patient forgetting. When they're in the office and they are chatting with you, it's really hard for them to keep up, I think, sometimes with what is the business that we're trying to accomplish, or what did I tell you to do? And if you don't write it down, I think a lot of, about 50% of them, they don't do it because it's not because they don't want to do it. They just can't. Their blood pressure was up so high when they were talking to you that they didn't put it all together. And so I think the after visit summary is one of those things where Meaningful Use is actually making us do stuff that we should have been doing all along. Keeping a problem list, having a good med list. So again, most doctors, after they quit hyperventilating, will see and I think appreciate that this is not a bad thing. This is good stuff, and you're going to help me be a better doctor. Here's my Meaningful Use slide. Does that about describe it? Say the arrows, the widths of the arrows are kind of related to how big an effort it's going to be, and just the whole picture. Notice MU1 over here is a little diminutive arrow, capture and share. Everybody succeeded. We had just about virtually everyone who was halfway awake collected on that. And stage 2, it's going to be a lot harder. 3, who knows? But certainly it gets more and more difficult as we go forward with these various stages. As I indicated, we have fully participated in stage 1 on the hospital and the ambulatory side, and have pocketed a fair amount of government money. Hopefully the gravy train will keep going, we'll see. But we have invested it and are moving along. It's interesting, MU1 I think was really about, on the ambulatory side, was about the personal performance of the provider. So you have to keep all these things I've listed there, and you have to do all of those things individually. It's interesting though that most of this data that we were asking docs to do on MU1, we really didn't get into the quality of those. So no one is talking about the quality of the problem list, or the med list, or the allergy list. And so I think that's going to be another interesting aspect. I do see that in 2 and 3 there is discussion, a lot of discussion actually, of getting information out to the patient so they can see what I as the physician think their problem list is, and then of course they're going to want to give us feedback, and I think that's great. So we've actually started having these conversations. What do you really want that problem list looking like that to go out on the after visit summary? And so we're talking about, we for a while were just putting new problems. If somebody went to the trouble to generate a problem, we would put it on the AVS. Now we're going to start doing all of them. And all of these hypokalemias and all these things from your inpatient stay, a year ago, are going to be on there. And we may have some discussion about cleaning that up. So again, I think that'll be a good thing as we start to use the problem list to help us take care of patients. So here's just some stats. I think I'll move along. Most providers succeeded, I think, is the key. Eligible hospital, again, is similar overall strategy. It was more of a group performance thing, though. We had departments that didn't touch the problem list on the inpatient side, yet we made the threshold as an enterprise, so we did fine on that. So we're now starting to circle back to those departments and really start to have some discussions. There was a little quality reporting, but one of the things we found is that the way the vendor requires that we do these various care, like stroke and VTE care, does not really mirror the workflow at KU. So Epic, for instance, would have several prescribed, well, really typically a single workflow that's prescribed. This is how you have to do these things in order for it to count on meaningful use, when that really didn't match with how we do that at KU. So we've kind of tried to make some efforts to improve that, but we really, our numbers are not very good, even though on other measures of our VT performance, it's very good. So we've kind of just let that kind of go as a quirk of meaningful use. I do think that one of the things about, after you get past the initial reactions, it really is an introduction to the power of the electronic health record. I guess I got it right, fixed that one. But, it really starts to show our providers what can happen when we interact with it in a meaningful way, beyond read it and find it. And so structured data, a fair amount of that there. There were easy thresholds, but what it really did is it started to get a lot of attention out there in the provider and of course the vendor community about meaningful use. And that's a good thing. And cash on the order of 12.7 billion doesn't hurt either in terms of focusing people's attention. So here's just some stats. 1 out of 2 providers as of this a month or so starting to participate. So that's really pretty amazing, I think. This is what some of our providers said. This too shall pass. I like the one, another short-lived government program soon to be reversed. That was a surgeon that said that. I think sometimes this program on Obamacare kind of get mixed up in people's minds, and they think that it's imminently repeal, and I keep telling them, I don't think so. It's amazing how we've kind of gone from that kind of talk to now really accepting it and moving forward. And I think that's kind of refreshing. We've gotten beyond, I'm not going to do it. We do continue to have problems though with the ophthalmologist, for instance, wanting to they don't want to collect blood pressures. They say, I don't do blood pressures. Don't need it. No ophthalmologic disease has anything to do with the blood pressure. And, they may technically be right, but I tell them, when the government passed 50% or so of the reimbursement, they can now tell us to do whatever they want. So you need to just move on from that. And we're gonna do obesity, smoking, and hypertension. And we'll make a lot of people better for doing that. And that's a tough concept to sell, particularly, again, in a volume-based world. But we're pushing that case. Another interesting thing in our enterprise is the difference. Some departments, those meaningful use dollars appeared on the bottom line. So it was like a bonus. Other departments, it just went into the big department black hole. Some departments know what that overhead is and what it goes for. Others have no idea. So you can just imagine you're in the lunchroom and you're having conversations with doctors about meaningful use. And this kind of makes the conversations pretty difficult when some are getting paid to do it and others not really. So, but that's just some of the things that CMIOs have to deal with. As I indicated, I think there's a bunch of cultural issues related to this that we're continuing to work through, and that's particularly around the management of populations of patients. Specialists have to measure and actually manage blood pressure. Although, we're really not trying to get them to manage it. We're simply trying to get them to refer to someone who can manage the people's blood pressure. So that's just a hard sell to make, and I don't have any problem, confronting docs and saying, look, it's the right thing to do. If they had a blood pressure of 210 over 150, you would have reported that anyway, wouldn't you? And so, we kind of work through it, but really it is something you need a physician to tell another one to sort of get real. I do think in terms of the value-based purchasing models, prioritization, I think it's pretty clear that we have a lot of work to do to get data from the bedside to the to the management area and with the provider there, so that we can see how you are individually doing with taking care of your patients. And we know it takes a long time to get evidence from the lab to the exam room, and we need to be about speeding that up. So it takes active supportive leadership, but it does take this prioritization I mentioned here, really in terms of all of the many things that we need to do at our institution. We need to prioritize these things that make the doctors better users, and adoption. Really, adoption is something I'd like to talk about now a bit, because I really think that this is the step that we all need to go on as providers, and this is how good your adoption is, and this down at the bottom is a time scale. So I hate it. This would be the standard about 2 weeks after go live. You're killing me. I'm not going to be able to survive. This would be 6 months into it maybe, and then I love it. This is really where we need to get people, is to kind of move through these natural progressions. And so how do you do that? How do you get people to go from I hate it to not only do I tolerate it, but I love it? One of the things I think that we should be doing is we should be looking at how people are using the system and really paying attention to what they're doing with it. If they are consistently not availing themselves of any of the tricks and tips that we've used or we have deployed to make them successful documentation experts, then we need to know that. We need to go out and we need to go seek out that provider and find out what's going on. Were they doing Facebook during that part of the training? That's a common thing. Were they too busy saving lives to come to training? That's a common why do you not know this? And we really don't want to wait for them to complain to us that you're slowing me down, because it's too late at that point. We need to identify these problems ahead of time. Some of the markers of being a good citizen with the EMR listed here, actually doing your documentation in the room. And Epic has a capability to measure from the time the roomer got done until the doctor goes in, how long does it take them to get on the computer and start actually doing something. And this can be shown as a department level statistic, an individual, and then an enterprise statistic. And sometimes these are things that are beyond the doctor's purview. If the IT system doesn't work, if you can't turn it on, or the roomer doesn't turn it on. One of our workflows around roomers is when they've gone in and they've done med reconciliation, they've done pharmacy, all of the tasks that they have to do, they are to enter the next provider coming after them. First of all, they need to know who that is, and then they need to enter their username into the logon field, and then so all the doc has to do to get documenting is to put their password in and start typing. And we're talking about type, talk, think, and listen. You need a new skill set in the EMR world, and that does not include having your back to the patient, while you're talking to them. So then we need to have the architects, and it's amazing how many architects don't know about all this. It's just absolutely amazing to me. But you set yourself up for failure if you have I can't blame a doc for not wanting to do that. But if you can have a triangle, David Varan is a big fan of this, a triangle with the computer in the middle and the patient and the doctor gathering around it, to use it as a first-class tool rather than something they're making me use. So meaningful use parameters are also tracked in this pulse system. And so what it does is every morning or you can do it like once a week, when you log in, you get your pulse statistics projected, and you can click through it if you like, but it's right there in front of your face. You can see your performance relative to your peers, which is always a good thing to show to physicians for the most part. These are other things that it can measure, including time to closeout visits and exam room orders. So efficiency, I think, is another key. I would really am trying to drive to a system where we can measure the number of RVUs per hour on the system. I really want to know how long you're messing with the computer. And I really don't, I think we need to be very careful when doctors are working at night at home. That is not the long-term ticket to paradise, as they say. You know, that is, you have got to know that, and you've got to be monitoring that. And we are not anywhere near where we need to be. But we should, you know, RVUs is a measure of productivity, relative value units, and then just time. So how long does it take to get you to produce whatever level you're trying to produce? So I think the other thing is clinical decision support. We need to have, and we do have a specialized group that develops clinical decision support and actually helps us with the overall burden. You know, so we want to be careful about alerts that don't do anything, that don't work. And somebody has to be tracking the total physician experience around alerts. And make sure that they're, all the ones that do fire are actually doing some good and not just noise. Because, you know, once you have a bunch of bad alerts that you have to fire through and ignore, when a valuable one comes by, you're likely to just, you know, blow by that one as well. So very important area in terms of value for docs. You know, we do a lot of things like reporting in the background before we ever turn it on so that we can see. And then, of course, one of the very important things is let's make sure this is actually doing what we thought it did. We try to avoid, you know, users coming to us to say, I'd like an alert to do this. You know, rather we try to have a conversation about what behavior are you trying to change? And then we can look at our whole, this is just a subset of the tools that we have available to get folks to do something different. So evidence, as I talked about earlier with the zincs, good to have it, better to use it. So a system to actually measure and provide feedback, because that's really where we're going to be stars in this new world of value-based compensation, is if we're performing to the highest quality standard, the best evidence, and we're actually, you know, using it. And the doc's going to want to know that, you know, I'm not, you know, it's not that they may be intentionally trying to avoid the evidence, but they may not know. So we need to be sure that we can get feedback to them on that. We had the whole discussion about create versus buy, and we elected to buy it so that we could move on to other more value add propositions rather than time in the library. And so drive performance and drill down, we think, are very important capabilities around evidence. So real time, we've also had some experience with this in terms of disease intervention, sepsis particularly, trying to identify patients. We have had pretty good luck on our core measure performance, and what we find is that we have a very rigorous kind of medical archaeology activity where, you know, it's 3 months later, you've got your core measures vendor has done all the processing, and now there's a problem here. But again, the patient's gone. The event is over. So it's very hard to find out what was the interaction that led to this performance, you know, with such a delay. So we're really trying to get to identifying care deviations right when they happen, rather than months later when it's going to be hard to intervene and actually get a process that works better. So risk, that was one of the topics covered today. I really think risk is going to be a great thing, because I really think that is going to focus our providers to pay attention when we come out with new stuff that's going to potentially help them, you know, interact with the system in a better fashion and be more successful. When we, you know, publish their performance statistics, they're going to pay attention, because, you know, with this risk comes compensation. So I like the little saying, if you're going to manage it, you have to measure it. And so we really need to design systems that allow us to measure and then report our performance. So it just looks to be like over time we're all going to be participating in some sort of risk approach. And as I've heard some CMIOs say, you know, there's no question that we're all going to participate in an ACO. It's just, are you going to be on the receiving end of it, or the, you know, the other end? So, you know, we need to get ready. I think it's important to focus on the value-added things. I've sort of mentioned these in the talk, but, you know, what are the things that we can do to help doctors do what they they really at their core want to do, which is take better care of patients and do it in a more efficient and effective manner. I think HIE, I do have a role in one of the HIEs because I feel that strongly, and our institution does, and the value of them. But you know, really, there is an incredible opportunity in an office and in the care conversation to, you know, right now we have to have the conversations about, well, was it a donut or was it really loud? You know, that's a CT versus an MRI. That's how you figure out which one of those they had. That's a long ways from the what's the result? You know, can I just, what did they find? And I even better want to look at the film to see if it was a competent radiology group that did it, or somebody that's, instead of the temporal bone right here, they're taking pictures down here, and that's a temporal bone CT. You know, just because it says it's this will be a good one for you as you're combing the Medicare data. Just remember that. Just because it says it's a temporal bone CT doesn't really mean that it is. But if we could look at those films, if we could actually see those, you know, and make a decision right there on the spot, we don't have to radiate this patient again. We don't have to bring them in. We don't have to schedule that. But actually see what radiology is available and the quality of it, and actually, you know, take that clinical information right on the spot. That doctors, I think, are really going to get excited about HIE when we get some of the bugs worked out. Clinical decision support, I've talked about this, but we need to be about the business of making sure alerts work, and they are doing things like dose calculation, like drug disease interaction, that we really have a hard time, you know, getting to in the rush of all the projects. But I hope part of MU3 might be really drilling down on alerts and really making sure that we're getting maximum value from alerts for our providers. And then efficiency. I think if we can start paying attention to the efficiency, docs will really appreciate that, particularly now. So in summary, I really think you know, that this is a great time for CMIOs because we're the alignment, just like meaningful use. While it did accelerate the trajectory of my career, it did focus people on getting to the power of the record instead of the peripheral, you know, read it and find it type stuff. And so I'm all for meaningful use. I could have some quibbles about the details of it, but the foundational concepts of it I think are great. And so I think these value-based payments are going to be a great, you know, motivator for really maintaining that expensive structured data. You know, it's expensive to create structured data. It takes time and it's hard to do. So, but this sort of paradigm really drives us to get that right and to be able to capitalize on it. So risk, like we talked about, is going to drive us to evaluate and manage. So this is really, I think, the bottom line is, as performance is valued more highly than volume, the computer will be seen as less the foe and more as a good and valuable tool. And so that's, I really think, what it's all about, is trying to get us past this, you didn't pay me to be a typist, to this is the greatest thing since sliced bread. And, you know, you need to be having those conversations, and I'm looking forward to it. So I think that's all I have today. If there's any questions.
Great. Dr. Ator, thank you very much. Do we have any questions from the audience for Dr. Ator? We have one over there.
Even stuff I didn't cover, I'd be happy to talk about it in terms of CMIO type role.
Well, I was just curious because you mentioned a little bit earlier about performance measures and how, I mean, that's going to be kind of the center of the whole value trend and everything. So are you looking at specific IT solutions, capabilities, like are you working with Epic at all in that area to kind of enhance the system to measure those factors?
We absolutely are, and I think I sort of talked about it, but Epic is really starting to see, again, because of their data model, that you really need to help people with the whole package. So when you roll out an orthopedic functionality like they're working on right now, we need to have performance measures around, you know, failed fracture repairs, refracture, you know, whatever indices, and particularly if they can be informed by the Orthopedic Society's measures or CMS measures, they are starting to actually do that and have that those report drill down capability like I've never seen them do before. So not only are they doing that, and they've endorsed business objects as kind of the approach that you need to use to. So those are business objects tools that are provided with your Epic material, and so provided you install it in a model fashion, these capabilities would typically work for you. I would really like to, in a medical staff executive meeting, for instance, show everyone's problem list performance and have the trend, and then maybe not in the meeting drill down, but I would like the chair to be able to drill down on the red, green, yellow dots and see who's not doing it. And then when we have a faculty meeting, instead of talking about anything but the red dot, we can go right to the red dot and find out what it is we need to fix. So you need tool sets to do that, and we're trying to develop that internally. But Epic is too, so I guess we'll see.
I had a question. The VA is being touted as sort of a good model for evidence-based medicine. Have you done any, have you looked at their system compared to Epic or any of the other systems?
Well, that's funny. The VA system, Vista, I think it's called. I actually did practice at the VA a little while ago, and then I got too old, so I got promoted out of there. But our young faculty go over there. But back then, and so I'm not really qualified to talk about the day-to-day because that was 10 years ago, and it was nowhere near what Epic has 5 years ago back then. And so Epic's documentation tools, the ease with which you can document or sometimes misdocument are unprecedented. I'm really not familiar though with their evidence approach. I think one of the things that we are finding with Epic particularly, not so much Cerner, interestingly, is that it's very hard to get, for instance, the evidence embodied in Zincs into Epic. And then when that evidence changes, how do you, so evidence is not a static thing. Every 6 months it gets reviewed by the vendor, stuff changes. How do you get that information back into the hundreds of order sets that we have? So, I'm not aware of the VA having that problem solved. Cerner, as I said, does have a very nice connection to Zincs. Zincs was actually owned by Cerner for a while, and they have a very smooth ability to exchange. I don't know if any of the Cerner customers would want to comment on that, but it really is very nice for getting stuff in and out. Joe?
Yeah, you can move in and out, getting to it, move it in and out of the author space tool.
Right.
Yeah.
Pretty hard in Epic, like I said, and I think that's just because of the differing kind of technical infrastructure that underlies the two products. But that, to me, that is really one of the big questions is we know all this evidence. Let's start having conversations about, are you performing to the evidence that we know? So that applies to radiology, and there's some very cumbersome ways to I don't think there's any way to alienate a doctor faster than, you're going through this whole paradigm I'm talking about in terms of just messing with the system and the kludginess of it to, and they're there for a headache, and you want to order an MRI after this grueling interaction. I'm playing a little bit the neurosurgeon perspective maybe, but at the end of it, it wants you to type in what their complaint is. Well, that's all we've been talking. That's all I've been screwing around with here for the last 30 minutes. You should know what their complaint is. So you want me to put it in there and just imagine how that goes. It doesn't. And as those approaches to PBM to our radiology management just haven't worked for those reasons. But we need to be able to do that and to stop somewhere around 40% of radiology that's not necessary and is not helpful. That's a great question. Any others?
You talked a lot about structured data, and obviously that you walk before you run. What is your view of the value of unstructured data to analytics? So obviously that would be mining within emails, patient notes, attachments, and where do you think that will play and when? will that impact?
Yeah, so natural language processing type endeavors. I actually think there's quite a bit of value to that right now. We do not at our institution, at any of the affiliates, allow for a total dictation. So you cannot produce a total textual note. And so we have something called partial dictation, where you can dictate the history of the history of present illness. The physical exam is typically structured, the past medical, social, all of that is structured, and then you get into physical exam, that could be a macro, and then assessment and plan can be dictated. But so the very important data elements, most of them are already in structured form, because that's kind of the way we've structured the system. It does seem to me, though, that there's great value. I think of things like the pathology reports and the radiology reports that have no structure. It's just a continuous blob of text. We don't even have markers for is it abnormal or not. So, we can't even start to look at that. So I think those type of reports could very much benefit from some structure. I think we're working with some companies around looking at the notes, around copy paste, around we have a problem in our physician population of creating notes that look like they're texts. They were going to appear on your telephone or something, and misspelled words and grammar, and we're trying to go around and find those preemptively. So there's a lot of, I think, power and progress we made. Epic is actually looking at that too.
Also, in structured sources of data might even be things that would come in via an email, come in via a patient portal.
Yeah.
There's lots of sources of data that
That's right.
May or not provide value.
That's right. That's it. Well, in the direct conversations that we're going to get into may well be, I would think they're going to be unstructured for the most part. So that's exactly right.
Okay, any final questions for Dr. Ator? All right. Well, let's take first thank Dr. Ator for his time.